Today we are talking about respiratory assessment. And it's got a little more detail than some of our other, some of the other things we've done so far. So we're going to go through some anatomy, talk about a lot of health history stuff. The actual hands-on assessment, I'll be honest, probably doesn't take a whole lot of time. There's probably more to the health history part almost than there is to the actual assessment, but we'll get to that. Okay, let's talk a little bit about A&P. Because you need to know your A&P in order to be able to understand what you're listening to, what you're hearing. And this A&P also rolls over into cardiac, which you'll be doing on Wednesday. So in your chest, in the mediastinal region, and the mediastinum is right behind your sternum, this is where pretty much where your heart lives. From there over on to the left side, your aortic arch, your lower esophagus, your lower trachea, and your superior vena cava. Now, what we're most concerned about, or what we're going to talk about the most today, is your pleural cavities. And your pleural cavities are where your lungs are. You have one on each side, and that houses the lungs and then the pleural fluid that is around the lungs. Okay, so why does our right lung have 3 lobes and our left lobe? Our left lung only has 2 lobes?
Our heart is on our left side of our body, so there's not as much space.
Correct. The heart is on the left side of the body, so there is not as much space on that left side. So that's why your right lung has 3 lobes and your left lung has only 2, because it has to make room for the heart. Now we're going to talk a little bit about the upper airway and what it does as opposed to the lower part of the respiratory system. So your upper airway is your nose, your pharynx, your larynx, and the part of your trachea that is upper. Basically, it not only conducts your air from, going into your body down to your lungs, but it also protects your airway from foreign matter. So you are doing spring cleaning and you go and you clean out that one closet that you haven't cleaned out in about 2 years, and you clean it all out and you dust everything and you sweep and vacuum and you put it all back, and when you get done your nose feels stuffy, and so you go to blow your nose. What color is the snot that's going to come out of your nose? What color is it going to be after all that cleaning?
Green?
Not green.
Black?
Black. It's going to be black. It's going to look like the dirt that you were cleaning, because part of what that upper airway does is it filters that foreign matter. So even when you're outside, like last weekend, I was outside doing some gardening, and of course it was real dry and dusty, and obviously I kicked up enough dirt that when I got home and blew my nose, I was blowing dirt out of my nose. But that's the purpose of that. It helps protect your lower airway so that all of that dirt and dust and stuff does not end up down in your lungs. It also warms and humidifies your air. Now, warming and humidifying isn't such a big deal like now when it's, 90 some degrees outside. But think about January when it's 20 below. We don't want that 20 below air to go down into our lungs. So as we breathe in that outdoor air, our body, that upper airway warms and filters in and adds humidity so that it is acceptable to our lungs when it gets down to our lungs. And this would be what your upper airway looks like, down to about the upper part of the trachea. So then we have the lower. And the lower airway structures include more of the rest of the trachea, your main stem bronchi, which then divide out into your bronchioles, and the bronchioles then become your alveoli, where your gas exchange actually occurs, which looks like this. So here's your trachea coming down, and we've got your right main stem bronchus and your left main bronchus, which then you see how it divides up even more down into that alveoli where your gas change occurs. And hopefully some of this sounds familiar from biology. Okay, so how do we breathe? When we breathe, our diaphragm and our intercostal muscles, where are the intercostal muscles?
Between your ribs.
Between your ribs, absolutely. Good job. So when we breathe, when we take a deep breath in, the diaphragm moves down, the intercostal muscles push the chest outward, and that's why our chest expands when we take a breath in. As those muscles relax and the air goes back out, those intercostal muscles relax, your diaphragm moves back up, and your chest gets smaller. So that's why you see the rise and the fall of the chest when you have inspiration and expiration. Now, what is an accessory muscle, and where would we find them on our bodies? Any ideas? Okay, so for those of you that have children, if your young child is having a lot of problem breathing, what do you see moving?
Their chest.
Well, yeah, their chest, but what about their abdomens? Don't they start to tummy breathe a lot when they're struggling? You may see, what we call retractions, which is when you can see all of the muscles up here in the upper chest and in those intercostals get kind of sucked in as they're trying to breathe. Typically, the accessory muscles kind of work in the background. They contribute, but we typically don't really see them in action until our patient is distressed and really having trouble breathing, and then those accessory muscles kick in. Okay, so we've talked about the airflow. It moves in through the nose, down the trachea, into the lungs, and then back out again. Okay, now when I talk about markers, this is what we use. You know, we talked about with the abdomen that we divide the abdomen into quadrants. And so if you're having appendix pain, you would have pain in your right lower quadrant. Okay. We use those markers. The markers that we're going to talk about are what we use to pinpoint problems when we're doing assessment in the chest and the back area. Okay, so just kind of bear with me as I talk through all of this. Actually, I think I'm going to skip ahead to my picture. There we go. Okay, so when we look at markers, so we start with, we have a suprasternal notch, which is right up here at the top of the rib cage, at the top of the sternum. And then we have the sternum that goes down the middle of the chest. That's kind of your midline. Then if you think about when we talked about apical pulse last week in clinical, we talked about that your apical pulse is in the midclavicular, so here's your clavicle, mid-clavicular line. So basically what's happening is we're doing these landmarks so that we can know how to find stuff on the body, on the chest, and how to tell someone else where to find it. So you've got your sternal, you've got a mid-clavicular over here, and actually you would have another mid-clavicular over here. If you look at the side of the body, look at them from a side view, you've got your mid-axillary line, which is right down the middle there. And then when you look at the back, you've got your vertebral line, which is down your spine. And then you've got your scapula, which are over here and over here. And then you've got a scapular line. So basically what it does is it kind of divides the chest and the back into sections. So when you find something abnormal, you can pretty clearly say where you found it, instead of saying, oh yeah, you know, it's in the upper right chest. Well, you can actually say, okay, it's in the, you know, upper anterior chest, mid-clavicular line, third intercostal space, which really says, okay, so I go there and I find that, and I should hear whatever abnormality or feel whatever abnormality you felt. Does that make sense? Okay. And all of those slides I skipped are descriptors of what's on this picture. Okay. We're going to take a break before we get into physical assessment. It's a good place to stop. So let's take 10 and come back at 2 o'clock, and we will continue onward. All righty. Is everybody back? Yeah, I always ask that, but you know, the people who are absent never answer me. I think that's truly a habit from too many years of being in the classroom type of thing. About the time I get used to this virtual, I'll retire and it won't even be an issue then anymore. Okay, so when we start with respiratory, and like I said, this is probably a little more detailed health history than we have talked about with the other systems, primarily because, of course, if they're short of breath or they have problems breathing, it is a big deal. And the fact that, you know, if you think about it, a lot of times these breathing problems are fairly common. And some of this will roll over into some of this will roll into cardiac that you're doing on Wednesday, because of course the cardiac respiratory system they're all linked together. So, you know, some of this will overlap with what you're going to talk about on Wednesday with Professor Punky, because a lot of times the two go hand in hand. So you're going to want to start with chronic illnesses. And this would be chronic illnesses, you know, respiratory chronic illnesses. You also may want to go into any cardiac chronic illnesses, because as I said, a lot of times, you know, if you've got someone who's got congestive heart failure, then that may also lead them to have breathing problems. So the two are kind of hand in hand. Any allergies? Think about those of you that have allergies. It may not cause a lower respiratory problem, but definitely upper respiratory when you're snuffling and sneezing and, you know, coughing and all of that. Does the breathing, do they have any problems breathing during doing their daily activities? You know, asking them things like, you know, if they say that they have problems, you know, well, how far can you walk before you have to stop to rest and breathe? You know, what can you do at home? You know, what activities can you do that make, you know, before you get out of breath? Those types of things. Do they have problems breathing when they sleep? You know, and that actually also rolls into, you know, somewhat of snoring. And do they snore a lot when they sleep? Because then that can lead to sleep apnea, which is also a respiratory problem. You know, what position do they sleep in? Especially, do they have to sleep with their head elevated on pillows, or do they just sleep in their recliner? There are a lot of these respiratory patients who don't even sleep in their beds. They sleep in their recliner because if they lay flat, they can't breathe, but if they get in their recliner, they can sleep just fine. Are they taking care of any? Are they taking any oral medications for a respiratory disorder? And as you would with any medication, if they're taking it, how effective has it been? And what are they taking? Do they use an inhaler? And inhalers have gotten really complex over the years in the number that we have and what they do. And it's not unusual to find our respiratory patients with two inhalers, or two types of inhalers. One would be their maintenance inhaler, which would be the one that they take every day, once or twice a day, no matter what, 365 days a year. And most of those may be like your steroidal inhalers, those types of things. They also will probably have what they would call an emergency inhaler. And their emergency inhaler is like their albuterol, which that they use when they're having an actual attack because it gives instant bronchodilation. It's going to instantly dilate those bronchioles in the lungs. The two cannot be interchanged. They can't use their maintenance inhaler in an emergency, and they can't use their emergency inhaler for their day-to-day maintenance. They do very different things. Do they use oxygen at home? And if they use oxygen at home, does it help? The other thing, and that if they're using oxygen at home, is you want to look at safety. Because if they've got oxygen at home, then you've got to, check into, is anybody smoking in the house? Is the patient still smoking? And believe me, I've seen people smoke on their oxygen. I'm seeing head nods from the people I can see. Yeah. But making sure that they're staying safe with their oxygen, those types of things, because it does happen. Have they ever had any problems with their lungs? Any respiratory diseases, bronchitis, COPD, asthma, chronic issues with pneumonia, that type of thing, or any type of injury to your chest? Do you smoke? And if it's a no, if they say no, I don't smoke, then your next question is, did you smoke in the past? Because we have a lot of people out there who have smoked in the past but have quit. So then we're going to do, how often do or did you smoke? And pretty much you're going to, really the best gauge of that we use is, how many packs per day do you smoke? Is it 1 pack? Is it 2 packs? Is it, how many packs a day do you smoke? And then have you ever tried to quit? And if you did try to quit, why were you unsuccessful? Now, if somebody has a history of smoking, we want to calculate their pack year history. And we do that by, and this didn't make any sense to the morning group, so I'm sorry if this doesn't make any sense, but this is just the way we do it. So just take my word for it. So to calculate pack year history, you're going to take the number of packs per day that they smoke times the number of years they've smoked. Boy, that's fuzzy. Hang on, let me see if I can focus here a little bit. Ooh, that's better. There we go. Okay. So what this is saying then is that, I'll do some examples here on my paper. If you've got someone who tells you that they smoke 2 packs a day and they've smoked for 50 years, what's their pack year history?
100.
100. Okay, so it's going to be 100 pack years. Okay. Let's say that you have someone who quit 10 years ago, but before they quit, they had smoked 3 packs a day for 40 years. What's their pack year history going to be?
$120.
120. Okay. Even if you, and you can calculate this, even if someone says they smoke a half a pack a day. So let's say they smoke half a pack a day and they've done that for 10 years. What's their pack year history?
5.
5. And so when you do your health history, what you're going to be putting in there is you're just going to be putting that they have a history of smoking of however many pack years they have. You know, for example, I know a cute little elderly lady who has smoked, she's in her 80s, she's smoked since she was 14, and she probably does 2 to 3 packs a day. So if you do 3 packs a day times 70 years, she's got a 210 pack year history of smoking. And no, she won't quit.
What do you do for people who, sorry, what do you do for people who smoke cigars? Or
you
chew?
You would probably, for smoking cigars, you would probably just spell that out and say that they smoke like 1 or 2 cigars a day and have done that for however many years, because typically cigar smoking is not as prevalent, so we don't see that as much. Chew, you're just going to put that they chew.
Okay, awesome. Thank you.
Uh-huh. Okay. And so this information should go into your health history. Okay. Is there a family history of lung disease? So is there a history of cystic fibrosis in the family? Is there a history of lung cancer in the family? COPD in the family? You know, you have some people where, you know, everybody on one side of the family always gets bronchitis every winter. You know, is there a family history of lung disease? Are there any environmental conditions that may affect your breathing at home? You know, when we talked about the dress code, about, you know, heavy perfumes and scents and stuff, you know, that could be an environmental condition. Or maybe you live out on a farm where they do crop dusting. And so when they crop dust and you've got your windows open in the house, there's the possibility that those insecticides and herbicides could get into your house. You know, those types of things you would want to look at. Where do you work? Or if they're retired, where did they work? Because especially with our elderly, you have to remember that a lot of the rules that we have today about protective equipment and respirator masks and all of that didn't exist back when our grandparents or our great-grandparents were working. You know, for example, if you've got an elderly person that worked in the coal mines back in the 30s, 40s, and 50s, they didn't wear any protective stuff in the coal mines. They just went in and did it. And so as a consequence, a lot of them have black lung disease. Black because the coal is black. The same thing with asbestos. We didn't always know that asbestos was harmful. And so there were many years when people would work around asbestos and never wore any protection. So that's why knowing your patient's occupation is so very important, because it can really give you a look back into their history. If they're currently working or they're currently working with irritants, do they wear a mask or some type of a respirator? You know, you've got some people, you know, who even though they know they should, they don't. You know, so you've always are going to have those people who, even if they're exposed to stuff, may not wear the appropriate equipment for whatever reason. I'll just say that this first bullet point is new this year. Any known exposure to COVID in the last 14 days, just like your little Health Check 360 asks you. Have you traveled to any foreign countries? Remember that a lot of these diseases, and COVID is a great example, originated in countries other than the United States, which is why they always ask if you have traveled out of the country within a certain time period, because you can pick up things when you travel. Histoplasmosis, actually, you can pick up histoplasmosis in the Southeast or in some places in the Midwest. Schistosomiasis, or severe acute respiratory syndrome, is very prevalent in Southwest Asia, the Caribbean, and Asia. So, you know, so making sure that if you've got, you're taking care of someone who has traveled, where have they been and what might they have been exposed to? Okay, so when we are doing, when someone complains of something, and probably the most common thing when you're doing your respiratory assessment that someone's going to complain of is a cough. They got a cough. They may also complain of shortness of breath. They may also complain of chest pain with breathing. Remember that chest pain with breathing is different than chest pain that you'll talk about on Wednesday with cardiac. You know, so if you've got really bad pneumonia or bronchitis and you're coughing, your chest is going to hurt just from the force of coughing. Doesn't mean you're having a heart attack. And just like with anything, when you find a problem, whether we're talking some type of a symptom or when we get into pain assessment or that type of stuff, this is what you're going to want to find out. When did it start? Where does it hurt? When does it happen? How long does it happen? What does it sound like? You know, like with a cough, does it sound like really gurgly, like they're going to bring something up, or is it just a dry, hacky cough? Does anything aggravate it or make it worse? Are there any related symptoms? What have they tried to treat it? And how severe in it is it? And typically the patient will judge severity as in how does it affect their activities of daily living. If it doesn't affect their daily, you know, their daily routine and their daily life, they may not go to the doctor for a couple of months until it's more of an annoyance than a real problem. With the cough, shortness of breath, the one thing that I didn't talk about on the previous slide is sputum. We want to know what their sputum looks like. We want, because the colors are going to tell us something. So when we talk about sputum, if they're coughing something up and you say, what does your sputum look like? And they tell you it looks white or clear, What does that make you think of? Is that something to be really concerned about or not?
No.
No, not really. It could just be excess saliva or something like that. What about if the sputum is brown or red? What does that tell us?
Blood.
Blood. Brown would be old blood, and red would be acute blood, like they're bleeding now. What about yellow or green? What does that tell us?
Infection.
Infection, absolutely. Yellow or green sputum is infection. And this is whether they are coughing it up or blowing it out of their nose. Just saying, because you'll get it, they'll have sputum both through both ways. Consistency, how thick or thin is it? And typically how thick or thin it is going to determine how easy it is for them to cough it up. Typically, your thinner secretions are easier to cough up than your thicker secretions. And timing. Do they cough like every time they smoke? Do they cough? Do they get a cough every time they go outside? Like, especially if we're talking in the winter, they go out in this extreme temperature change and they start coughing. So what is the timing? Okay, so any questions on health history? I know that that was a lot more detailed than what we've talked about with our past sections. Okay, hearing silence, I will move onward. Okay, so general inspection, we're going to look at a couple of things. We're going to look at their general appearance. We're going to look, as we talked about with the skin last week, we're going to look at their skin and see if they have those pink undertones. And in order to do this, especially if you're talking about a person who has darker skin tones, you're going to be looking at things like their fingernails, the palms of their hands, their lips. We want that all to be pink. What does it mean if we look at their nail beds or their lips and they're blue? What does that tell us?
Lack of oxygen.
Lack of oxygen. That tells us that they're cyanotic. So we want to look at that. So what is their general appearance? You know, how are they breathing? You know, does it look like they're breathing easy, or does it look like they are, you know, having difficulty breathing? Okay. You're going to look at their respirations, and we just talked about respirations when we did the lab last week. You know, how fast are they breathing? Is their breathing regular or irregular? Is it really deep? Is it really shallow? Typically, if they're having shortness of breath, their respirations are going to be rapid and shallow. And what type of lung expansion are you getting? Does it look like their chest is fully expanding or not? And then we're going to look for clubbing. Can anyone tell me what clubbing is, and where would I look for it?
The fingernails.
Yes, it's
Yeah.
on the fingernails. Okay, and what's it going to look like, Miranda?
Kind of like rounded, I think.
Yep, you got it. So this is not, just to be perfectly clear, this is not like, you know when you see people with long fingernails and then their fingernails sometimes curve? This isn't what we're talking about. We're talking about actually the end of the finger curves. And that is caused from the lack of oxygen that they have experienced over many, many years of smoking or COPD. So you're not going to probably see it unless they've had something like cystic fibrosis. Cystic fibrosis is probably the only pediatric respiratory disease I can think of that might cause clubbing in a young adult. But in your, 80-year-olds who have been smoking for 50 years, it is not unusual to see that curve of the finger, and that's called clubbing.
Professor Moore,
Yeah.
I had a question. The people with like the big fingers.
Oh, you're really echoey there, Sky. Try
Hear me now?
there. That's better. Thank you.
Okay, like the people with like the big fingers that look like light bulbs.
That look like what? Sorry, I've got a dog barking in the background. Say it
I
again.
don't know what's going on. Hold on.
Say it again.
Can you hear me now?
Yeah, I can.
Okay, I'm like, I don't know what's going on. But you know, people like the light bulbs, they like light bulbs on their fingers, their
Yeah,
fingertips.
yeah,
Is
the
that what
light.
you're talking about?
Yeah, that's yeah. So yeah, they've got their fingernails or their fingers look kind of rounded, kind of like light bulbs. Yep.
Okay, that's what I thought you were talking about, but it just sounded different the way you worded it.
That's okay. Yep. Nope. That's exactly what I'm talking about. And typically when you get their history, you're going to find that they have a long history of smoking, typically multiple packs per day for years. Okay. One of the other things.
I told you that's.
Huh? Okay. One of the other things we're going to look at is something called your ratio of AP to lateral. Okay, and actually I'm going to find my picture from this morning. Here we go. Okay, so there we go. Okay, so this is looking at someone's chest like from their head down, okay? So when you look at their head down, they should be kind of an oval. So if this is their front and this is their back, if you look at it, the distance from their front to their back should be 2 times side to side. So we say that the ratio of AP to lateral is 2 to 1. And that would be normal. Okay, so now let me show you abnormal. This would be someone with COPD who has what we call a barrel chest. And a barrel chest is just what it sounds like. So there you can see that the front to back is actually the same as the side to side. And that tells you that that is an abnormal. That would be a 1-to-1 ratio. So when you document this, if it's normal, it's going to look like this. You're going to say that the AP to lateral, so AP dot dot lateral, that's your ratio sign, equals 2 to 1. And that would be your normal. Does that make sense? Any questions on that?
I'm confused by that.
Okay, what are you confused about?
Kind of the whole thing.
Okay, so when you look at someone, so let me go back. Hold on, let me go back in my PowerPoint and see if I can show you a little better. Let me go back in my PowerPoint. Whoops, that's not what I meant to do, but that's okay. I can fix that. Okay, so let me come back to this picture. Okay. Okay, so when you look at this picture, okay, so when you're looking at AP, which would be anterior to posterior, so it would be the distance from the front, from the front to the back. And you're just kind of eyeballing it, honestly. And then what you're going to do is you're going to look at that, and then you're going to look at the distance from side to side. And the distance from front to back should be, you should be able to fit 2 of those in the side to side. So your AP is twice your lateral. Does that make sense? Is that a little better?
Yeah, that makes more sense.
Okay. All right, and let me get back to where, there we go. Okay. Okay, now I will tell you that this is in the wrong order because we should always palpate before we auscultate. Just telling you right now that that's wrong on my slide. So the first thing we're going to do is inspect, and just like you know, we do with anything, we're going to look. We're looking for symmetry. We're looking for shape. We're looking for muscle development. Now, when you're doing this on your partner, and like when you do it in the lab in a couple of more weeks, what's going to be the best thing for your partner to wear to make this a chest assessment easier?
A gown
Well, we don't have gowns in assessment labs, so
or t-shirt?
A cami?
okay, something like a cami or a tank top or a sports bra, because we really don't want you to we don't want, obviously we don't need to see everything. So, you know, something like a sports bra, a tank top, a cami, that you can easily lift up and down or work around. Because remember, we only put the stethoscope on skin. So then when we palpate, because we're going to inspect and then we're going to palpate, and we're going to palpate, hold on, I know I have a picture somewhere. Oh, well, I'll just draw one. Okay. So let's say that, there we go. So let's say that this is our spine. Okay. And you will find very quickly when we do this drawing stuff is that Professor Punky is the artist between us. I can't draw my way out of a paper bag. She creates beautiful artwork and I'm just like, really? That's not me. So anyway, if this is your spine, then you're going to, just like we did on the abdomen, you're just going to take and you're just going to press just like you did on the abdomen around that spine, feeling for any lumps or bumps. Okay. Then the slide also talked about thoracic expansion for palpation. What we do for this, and you're going to see it in the video, is you're going to put your hands on either side of the spine, and then you're going to ask the patient to take a deep breath in. When they take a deep breath in and their chest expands, your hands are going to move, and then they're going to go back. And it should be symmetrical. That's what you're looking for. It's not a how much do they move, it's a do they move symmetrically and back symmetrically with each breath in and out, and you'll check that. And like I said, you'll see that in the video. Okay. So that would be posterior. So then anterior, we're just going to inspect and auscultate. Why wouldn't we palpate as a general rule? I mean, you could actually say per gender, but it's just easier to just say we're not going to do that. Why wouldn't we palpate the front? What do women have in the front?
Breasts. Boobs.
Their breasts, absolutely. Okay, and so we'll talk about actually auscultating When I show you auscultating, I'll talk about that too. Once again, when you're looking at the front, you're looking at shape, symmetry, and muscle development. When you auscultate, we'll pretend once again that this is, your spine. We'll start in the back. You're going to go start on one side, go to the other side right across, come down, across, down, and across. So you never do, when you auscultate, you never go all down one side and then all down another side. We're always going to go from one side to the other, then down and across. So kind of like a big S or a big, zigzag type of thing. Now, when you do that in the front, you're going to go side to side, down, across, and then if it's female, if your patient is female, you're going to either ask them if they're comfortable with you lifting their breasts, if their breasts are really large, or have them do it. And then when you go down, it's going to be under their breast on both sides, just like you did with apical pulse last week. Remember that when you auscultate, you want to make sure that you're between the ribs, not on the ribs, not on the scapula, because if you're on the bone, you're not going to hear anything. So if you listen to their lungs, front and back, and you don't hear anything except the air going in and out, no funky sounds, and we're going to listen to sounds in just a minute, how do you think you document that? What term would
Normal
you
breath
use?
sound.
Okay, I'm going to tell you a secret. It's really not a secret, but I'm going to tell you a secret. In our assessing and our documentation, we never, ever use the word normal. We always assess what we see or hear, because my definition of normal might be different than Paula's definition of normal, which might be different from Gina's definition of normal. So if we don't hear anything, we're going to chart that the lungs are clear. They're clear to auscultation. Okay. Now, okay, so what I discovered this morning is that it's much easier for you to hear these YouTube things if I disconnect my headset and the volume's just coming out of my computer audio. So if I start to talk and you don't hear me, someone say, plug your mic back in. Okay, so we're going to listen to some YouTube videos.
At Aspen Dental, smile for zero money down with zero interest if paid in full within 18 months.
Okay, so crackles. Oops, I did it again. Dang it. I knew I'd do that. I knew I'd start talking. Okay, so crackles happen when we have water in the lungs, some kind of fluid, maybe not water, some type of fluid in the lung, whether that's from pneumonia or an infection or whatever. So it's kind of a low-pitched, bubbly sound. So I'm going to start it again and let you listen.
So did you hear kind of the crackling?
Were you guys able to hear it? Yes, I'm seeing Blaze nod yes.
Yeah, a little bit.
Okay, you can also go on to YouTube. I mean, this is where I pull my videos from, and you can type in something like crackles, and you can, you know, find some on your own that you might be able to hear better. Okay, so let me go to the next one. Stop. What? Okay. Sorry, I had way too many things going on at the same time. Okay. Let me get you so you actually are seeing YouTube. And let me back this up and
Okay, so that was wheezes. Wheezes.
more of a high-pitched, kind of a squeaky, musical type of sound. And then the last one we're going to listen to is a friction rub. And a friction rub is going to be different from the crackle. The crackle we only heard on inspiration. The friction rub you will hear on both inspiration and expiration.
You have to try Monday.com. Monday.com is a platform to track everything your team is working on. We use it for all our projects, marketing, product.
All righty. Okay. So when we diminished, when we're talking about breath sounds, diminished is just what it sounds like. That means that even at full lung expansion, their lung sounds are really soft. It's not unusual, especially in our elderly, for their lung sounds to sometimes be diminished down in the bases of their lungs, because they just can't get the air down there like they used to. And then, of course, absent means you hear nothing. Absolutely nothing, which, depending on your patient, may be a normal variation or may not be a normal variation. For example, if you've had someone who's had lung cancer and has had a lung removed or a lobe of the lung removed, you're not going to hear any sounds where that lung or that lobe was removed. So then it would be normal for that person. Now, if they haven't had any of that done and you don't hear any lung sounds, then that would make it more emergent, because you should hear something when you're listening to the lungs. Okay. Okay, so let me switch back to YouTube.
All right, I'm entering the room and washing my hands.
Yeah.
Hi, Mr. Hoffman. My name's Nancy. I'm going to be your nurse this afternoon, and we're going to be doing an assessment of your respiratory system. Is that okay? All right, I'm entering the room and washing my hands. Hi, Mr. Hoffman. My name's Nancy. I'm going to be your nurse this afternoon, and we're going to be doing an assessment of your respiratory system. Is that okay?
That's fine.
All right, I want to start out with 2 questions. Do you smoke cigarettes?
No,
And have you ever smoked?
no.
Do you have any history of lung problems like asthma, emphysema, bronchitis?
I have no.
Okay, all right, good. So I'm going to proceed with the assessment. First thing that I'm going to do is I'm just going to be observing and looking at the chest, and this is the inspection. So I'm first noting his respiratory rate is within normal limits. That's how fast he's breathing, and the rhythm is regular, meaning it's a nice, normal, regular pattern. I see your respirations are deep. I do not see any retractions or bulging of the interspaces. I see you're sitting up straight as opposed to leaning over, trying to catch your breath. And I see that the chest is symmetric. I also notice that the anterior-posterior ratio to the transverse ratio is 2 to 1, which is normal. Then I'm going to continue my inspection, also looking posteriorly at the posterior chest. Same thing, looking for any abnormalities for the shape of the chest, which is within normal limits. The chest should be shaped like a cone. All right, then I'm going to continue the assessment by palpating the chest. I'm going to touch you, and I'm going to touch the chest all over. Please let me know if you have any tenderness or pain in any areas. And lift up here. And I'm checking for anything abnormal, bumps, bruises, masses, pain, tenderness. I'm looking at the skin for anything abnormal. I'm looking at the color of the skin while I'm doing this, particularly looking for pallor, okay, pale, or cyanosis, which would be blue. And then can you stand up for me for just a second and turn around? And I'm going to check the expansion of the chest by putting my thumbs right here. And then can you take a big breath in and out? Okay, and you see my hands move in and out. Do that one more time. In and out. Good. Until the chest expands symmetrically. Have a seat again. And then I'm going to continue with my assessment by auscultating lung sounds. So I start with auscultation at the trachea. And then I want you to open your mouth and breathe a little bit.
We don't have you guys start
auscultating at the trachea. We have you guys start auscultating at the top, at the apex of the lungs or the top of the lungs. So I'm gonna let her go on, but just note that we don't have you guys listen at the trachea.
Deeper than normal, in and out. Not too deep, just a little bit deeper. Good. And I'm going to continue listening. I listen to a full breath in each spot. And I compare side to side as I go down the chest. Good. Are you okay? Feeling lightheaded or anything?
I feel fine.
Okay, so just be normal for a second. Even on a female patient, you're going to listen in this pattern, okay, around here, and then you can lift up to listen down low. So you can listen above the bra here and below the bra across here. And then I'm going to listen on each side. So left lateral, can you lift your arm up? Listen in 2 places, big breath. Again. All right, and can you stand up for me? Turn it this way. Okay. And then right laterally, we're going to listen in 3 spots. So on the right, there's 3 lobes, so you listen in 3 places. 1, 2, 3, like a triangle. And then posterior, we're going to listen, starting at the very top. The APCs of the lungs come way up here. A big breath. Open your mouth and breathe in and out through your mouth. I compare side to side. And I'm going around the scapula. One more. Okay, good. Have a seat. So over the trachea.
All righty. So did you see that? And I think I kind of alluded to it, but I didn't mention it. Did you see that when you're auscultating, you're not only doing the front, the back, but you're also doing the laterals down the sides also on both sides? Okay. Any questions on that part? Okay, I'm going to take your silence as a no. Okay. So oh, go ahead.
Okay, so I want to make sure I'm hearing this right. So you said that the sound we want to hear is just basically them breathing in and out, but we don't want to hear like the crackles or wheezing and stuff like that.
Correct.
Right?
Yes.
Okay, so it's not no sound is normal, but just like them breathing.
Correct. You should hear the air go in and out, but you shouldn't hear any of the extra sounds.
Okay.
Good question, because no, you shouldn't hear nothing. Hearing nothing would either mean you have your stethoscope wrong or there's something really wrong with your patient.
Okay, could you actually go over the diminished thing you said one more time?
Okay, so the diminished just means that it's not as loud. So a lot of times, especially in our elderly, you may hear pretty good up here in the top, but as you move down, you may not hear as well because they don't get good lung expansion into the bases of their lungs, and so it would be diminished.
Thank you.
Uh-huh. Okay, so this is what you're going to be documenting. And I believe there is a sample on the next slide. Okay. One of the things I didn't talk about, this kind of rolls back to head and neck, but it's still part of respiratory, is the trachea being midline and patent. Basically, if your patient is breathing and talking to you and they're pink, their trachea is patent. It would not be patent if they were choking or something like that. So that would be that it was patent. So that would be, this time you're going to have the 2 paragraphs for your narrative. You're going to have the 5 to 8 sentences of demographic health history, and then your respiratory documentation as your second paragraph. Okay. Any questions on that?